Good afternoon, hello, and thank you for joining us today for our virtual Healthy Minds, Healthy Bodies seminar. As a reminder, all lines will be muted. The presentation will also be recorded and provided in a follow-up email. Please submit any questions via the Q&A box. Questions will be monitored throughout the duration of the seminar, and time will be reserved at the end for the presenter to address these questions. We are going to do our very best to address all questions that have come in during the presentation, but if we reach the closing time of today's event, for any questions we are unable to address, answers will be provided in the follow-up email that you will receive, which will also contain a link to the webinar recording. A link to a survey will also be provided at the end within the Q&A box, so you may give us your feedback regarding today's presentation. All right, we have two presenters today. Wes Sedlacek is one of our chaplains and provides services in Lynn County at Samaritan Albany General Hospital and Samaritan Lebanon Community Hospital. Also joining us is Molly Gage. Molly is a licensed clinical social worker and provides services for Samaritan Support Services, palliative care. And now I'm going to hand controls over to Wes, and he will be presenting first.
Thank you very much, Erin, and welcome to all of you who are joining us for this event. This is a topic that is near and dear to, I think, both of our hearts, and we're glad to be able to be here with you. We have a couple of goals that we'd like to accomplish today, and so the first thing that we'd like to cover is that. We would like to explore the concept of quality of life. I'll talk a little bit about that. And then we will recognize how quality of life may impact medical decisions. And then finally, we are actually going to look at the Oregon's Advanced Directive and the POLST form, how they're similar and how they're different, so that you can have a feel for those documents as well as a way of expressing your wishes and preparing for the care that you would want. So first off, when it comes to quality or quantity, oftentimes we are in a place where we are hoping for the best quantity and quality of life. So quantity, when we talk about that, it's the length of life. So we might be trying to live as long as possible. And for many people, I've heard people that I've talked to say that their goal is to make it to 80 or 90 or even 100. They have goals that they've set for the quantity of their life. And so this graph here just is a visual reminder way that we all have different quantities in terms of how long our lives last. But then there's the quality of life as well. And quality is how well we enjoy the life that we are living. And so that's very frequently subjective. It's based on my own personal understanding of my enjoyment of my life. And so I can't determine what anybody else's quality of life is. I often talk to people in a setting to do some advanced medical planning and ask them about their quality of life. And sometimes people come to me with all sorts of illnesses, and I think that they're probably going to be at a certain level, and they surprise me and say they're at a much higher level, perhaps, or the other way around. There are times that people seem very healthy, and when I ask them about their quality of life, it's actually relatively low. So there are a lot of different factors to quality, whether it's your physical mobility, it's your thinking, your ability to think and process, whether it's your ability to communicate. These, again, are all very subjective, and so we get to decide for ourselves what our quality is. This graph here just sort of, again, exemplifies how different people might rate their quality of life in terms of looking at it in terms of a figure. Now, as I said, our goal very frequently is to live at the highest quality of life for as long as possible. And so this often leads to what I call the right angle death, where we are just having a great life and everything's good, and then we die suddenly and peacefully. You know, I'm sure many of us, I have said it myself, I would just like to die peacefully in my sleep. And that's the type of thing where you're just going along, everything's fine, and then boop, You hit an edge and there's your death. And so this graph represents our highest quality for as long as possible. But we don't always get that. Sometimes we have illnesses and other things that get in the way. And this is a study. There was a study that was done back in 2008, and they showed sort of the decline of 3 specific illnesses and how our quality of life tends to be affected by them. So the first one is cancer. And so this graph shows how someone diagnosed, and I should say that this is likely terminal cancer. They didn't designate that specifically, but because of the drop off to death, I'm guessing that this is a terminal cancer diagnosis. So you're going along pretty high and you have a diagnosis. You might have a few treatments or things, and you find that your strength and your wellness come down a little bit, and maybe things just get a little bit more difficult. And then there's sort of a more precipitous decline to the end. Whereas with another illness, such as a chronic illness, these would be something along the lines of congestive heart failure or COPD, the breathing illness, those types of things. Those illnesses get worse as they go along. And so you're kind of going along at a higher level. You might have an initial little blip where you get diagnosed, perhaps. And then you're sort of at the same level you were at for a while, and then you notice a little bit of a decline. You might have another hospitalization where you dip down a bit. This graph just sort of shows how the events in the hospital tend to get closer and closer when we have a chronic illness like one of these, and also how our quality of life just declines as we go along with each event. Oftentimes when I'm talking to people about their wishes and about the fact that we might go into the hospital at one level, coming out of the hospital, we won't necessarily be at that same level. We might get back to it, but we might be lower. And so then that's where we have to decide, is that going to be acceptable for us? The last decline that they showed in this particular study from 2008 was the decline from dementia or frailty. And so this is a case where oftentimes if our lives are prolonged and we're not maybe as able to think clearly and communicate, or because our bodies are getting very frail, this is a place where we're probably at a lower level of quality of life because we can't do the things that we once did, and we might not have as much enjoyment in the life that we have, and yet our life continues to sort of string out in a longer path. Any of you who have experienced the illness of Alzheimer's, for example, will know that very frequently people, their bodies keep going even though their minds might not. I had a great aunt who, she lived for quite a while with the disease, even though she was no longer, after a certain period of time, she became very much like a little girl. And it was just very difficult to see how her body just kept going. And so she was at a lower level for much longer. So again, going back to this chart, is the goal quality or quantity? So when we're looking at advanced medical planning, I think that's a big part of our decision, is to figure out, what are we trying to accomplish? Are we trying to get the best quality of life that we can have? Or are we trying to extend our life for as long as possible? And so if you haven't already addressed some of those, I encourage you to consider thinking about that in terms of your own care. One of the ways that I've addressed quality of life in conversations with people is to look at it through a 0 to 10 scale. It allows the opportunity for us to be able to again, that subjective nature of it's my choice. It allows us to be able to put ourselves on a particular scale. Now, initially when I created this, I was putting my own values into what created a 0 and what created a 10, and I realized that was not it, because again, I can't determine what your perception of your quality of life is. And so I usually just say, if you think of 10 being the best quality of life that you can imagine, and 0 being the absolute worst quality of life you can imagine, think briefly about where you might put yourself on that scale today. Ourselves on a particular scale. Now, initially when I created, and then that gives us the opportunity to figure out where on that scale we might be. So if we're at a higher level of care or a higher level of quality, we then probably don't need to, or we probably would want to do more aggressive type medical interventions. Whereas if our line starts to drop, our number starts to drop, we might opt to do less aggressive interventions. And so this next bit of the slide shows how that might correlate to the scale. Now, again, this is just me putting words onto a scale. You may be totally different. You might have your line in a totally different place, and you might also want aggressive measures at a lower number. That's totally fine. This is just a visual example of where it might be. But for example, in my case, I might want aggressive care if I'm in an 8, 9, or 10 of my quality of life. Whereas if I get into the middle, I would move more toward maybe not as aggressive measures, but more still basic curative things that I would be able to receive. And then the red line designates hypothetically where my line would be to say, if I dropped below this line in my perception of quality of life, then I would simply want to be kept comfortable and not maintained any longer. And so this is just another visual example of how we can get into this quality of life conversation. The next slide just shows a variety of photos just to give, because sometimes we don't even know what questions or what things to be thinking about. So this just gives you a variety of things to consider when you're looking at quality of life. What represents quality for you? Is it a matter of being able to garden and to do the things that you like to do? Is it a matter of being able to get out and walk around, to be with family? For some people, that middle picture, it's perfectly acceptable to be bedbound and to be living in a bed in a facility. We've had several people as patients in my time at the hospital that is their baseline, and they enjoy life even though they live in a facility. And see, there's my own value. I just said it. They enjoy life living in a facility and being restricted solely to a bed. But for other people, that might not be a quality of life. Similarly, is it okay to be in a wheelchair or to be immobile in some way? And is it important to have dogs and pets and other folks around you? So these just give you some further ideas of how it might be when you're assessing your quality of life. And so in addition, here are some questions to consider when you're looking at this. What is important to you overall? Is it important, again, to have the best quality, to have the best time of your life? Or is it best to have the longest amount of life? Next, where is your line on that 0 to 10 scale? Now, that could change. You might get to a point where down the road you're actually at that line and that's an acceptable quality of life. That's totally fine. But when it comes to looking at it now, maybe you can get a feel for, you know, if I were at this point, I might not want these types of things. One of the things that drives that for me when I bring that up is there was a doctor in a video I saw one time who was diagnosed with Lou Gehrig's disease, or ALS. And when he was diagnosed, he wrote up a list of 100 things that he could do at the time. He told his wife, you know, he could sit at the bed, he could tie his shoes, he could play tennis, he could read. He told his wife that if he got to the point where he could only do 15 of those 100 things, that's where he wanted to be just simply kept comfortable. So he established that idea of a line for me. And so that's what's made me think that each of us has that line. So where is your line? How much are you willing to endure when it comes to medical care? Is it important to, again, to have the largest amount of time and go through a lot of different treatments, have all the various things, tubes stuck in you and do things like that? Or would you rather not have all those types of interventions? So how much are you willing to endure? And then at what point would you perhaps wish to focus on comfort? So these are just some additional questions to be able to consider when you're looking at the overall picture of quality of life. And then once you do that, then you can start looking at the documents that we have that allow you to put those wishes, those thoughts into practice. And so now I'm going to hand it over to Molly to let her talk a little bit about those documents. Molly?
Hi. Do I have control? So I'm going to talk, thank you for coming, everybody, and hello. I'm going to talk about the two most common and simplest ways that we have to document your healthcare wishes in Oregon. And those are the advanced directives and the Oregon POLST form. Now, these two forms are often confused. They have a similar purpose, but they're quite different. We advocate that anyone over 18 in the state of Oregon should have an advance directive. That's a document that you fill out yourself while you have capacity to do so. It's a legal document when it's witnessed or notarized properly, and it tells what kind of care you would like if you were in a hospital type situation. It also appoints a healthcare representative to speak for you if you can't speak for yourself. And the focus is on life support and tube feeding. And I'll talk more about the document itself in just a minute. It is a legal document, and so it describes what your wishes would be if you come to be in the situations described. A POLST form is only recommended for people who are more frail already, elderly, perhaps have a terminal illness, and are more towards the end of life, perhaps, or just want to limit what medical treatments they received. It can be completed by somebody other than yourself if you're unable to complete it yourself. It requires the signature of a healthcare provider, so a doctor or nurse practitioner, and it may describe the care you receive at home as well as in the hospital. People sometimes have heard of the DNR orders, and this is where you would put that into writing that you want do not resuscitate. And we'll talk about that in detail also. The POLST is actually a medical order, so it defines the care that you will receive from emergency responders or in the hospital or from your own doctor. So similarities of these two forms is they allow you to put your desires for medical treatment on paper, and they can be amended. You can both have slots to write in additional comments. They can be updated, and it's recommended that you do look at them every so often and make sure that they still represent your wishes. And if you're alert and able to speak for yourself, that's going to be what comes first. You can override what you've written on paper if you're able to speak, or if you've put a healthcare representative in charge and they want to override what you say, that can be done as well. If there's time. In the situation with CPR or do not resuscitate, there may not be time. So first I'm going to talk about the advance directive. These may or may not look, you may have seen these before. They're both relevant. The one on the right's a little more recent than the other. I've heard that they're working on a new update. So either one of these is valid. And the Advance Directive Workbook is put out by Oregon Health Decisions. It's in a magazine format, and it's encouraging people to have discussions with their families about their wishes. So there's a section called the Conversation Starter with brown edges, and that tells stories about people in certain situations. For example, with a terminal illness, with a chronic illness, with advancing dementia, someone who's been in a car accident. And it talks about the decisions that those people have made and gives the background for why they made the decisions that they did. And then the yellow section allows for a lot of detail to help you think through, what if I were in that situation? What would I want? And that can be helpful to look out, to read through, to discuss with your family, and to put in writing so that there's more detail if this is ever needed for somebody to represent you and your wishes. The blue section of the notebook is what the legal document is. So you can appoint a healthcare representative who will speak for you if you cannot speak for yourself. And it says what you would want in certain situations if you're approaching the end of life. A couple things to know. This is not the same as a power of attorney for legal and financial affairs. And so that document won't cover healthcare decisions unless it says it does. This is separate. My screen just went blank. And think about whether you would like the same person to do your healthcare representation or your financial decisions, and who you may not want to be that person. You want to choose somebody who's going to follow your wishes to the best of their ability. So a couple questions that it will ask about end-of-life care. Do you want life support, which would be any medical treatment that maintains life by sustaining, restoring, or replacing a vital function? And would you want tube feeding if you were unable to have food or drink by mouth? Those are big questions at the end of life.
Molly?
Yes.
If I may, just the phrase that I've started using with the life support is that if you think about it as something that takes the place of something your body would normally do. Mm-hmm. So if our most frequent use of that is the breathing machine that breathes for you, but kidney dialysis, the ECMO, the stuff that bypasses your heart, those types of things are all those aggressive life support measures. So just as an FYI.
Yes, thank you. And so when we're talking about end of life, you will always be treated by care providers for comfort, which means trying to alleviate pain and suffering, with dignity, which means your body is cared for, and with respect, with knowing that whatever your capacities are, you're a human being. I'm going to move on to the POLST form. So this is has been recently updated. So again, there are a couple different versions out there. The former version was called Physician's Orders for Life-Sustaining Treatment. This one's called, the new version is called Portable Orders for Life-Sustaining Treatment, because other medical providers besides a physician can sign this. So portable orders for life-sustaining treatment. Portable meaning that it goes with you, home or hospital, wherever you may be receiving care. So there are two sections on the POLST form. One is whether or not you would want cardiopulmonary resuscitation or do not resuscitate. And that's when you've died, when you don't have a pulse or you're not breathing. Would you want for someone to attempt to bring you back to life through the means of CPR? The other question it asks is, what level of care would you like? Comfort only, limited treatment, or full treatment? And so comfort measures only, were you to choose that, would mean maintaining comfort through cleanliness, positioning, and wound care, relieving pain and suffering through the use of medication, using oxygen, suction, and manual treatment of airway obstructions, and taking food by mouth as you are able to. And that's often done without ever going to a hospital. Often people who are tired of going to the hospital are people who may choose comfort measures. If you have a terminal illness and a prognosis of 6 months or less, hospice are the comfort care experts, and that would be the time to choose hospice if you're allowing your body to do what it is doing. If it's shutting down, and but you want to be comfortable in the process. Limited additional interventions means that you'd like to receive antibiotics, IV fluids, or other curative medications. That may mean that you're receiving artificial nutrition, artificial hydration. It may mean that you're using a BiPAP or a CPAP for oxygen. It probably means that if something goes wrong, you want to go to the hospital and have them treat you. Full treatment means that you'd like every aggressive care that we can throw at you. It normally means that you would be receiving care in the intensive care unit, and that you would be using machines to breathe for you, to do other bodily functions like Wes described. So people come to a point where they say, maybe I don't want full treatment. Maybe my quality of life is such that I want to spend time at home rather than in the hospital. And that's when they may consider limiting the treatment that they're receiving. Personal choices, as Wes was speaking of. So I think that I'm turning this back to Wes. Yes.
Okay, so what we encourage people to do next, perhaps, is to have a conversation with your family, with your loved ones, the people who are around you who might be a part of the decision making, and tell them what you've decided. Even if you haven't written anything down, having the conversation can be very important, because I've seen a number of families who have been devastated because it was just never a conversation that even started. But even if they didn't have anything written down, if they had the conversation with somebody, they could usually say, well, I know mom wanted this, or I know dad really wanted this, and it gives them some sense of comfort to know that they are acting in line with the wishes of their loved one. So just having the conversation is the basic step. So once you've written some things down on a piece of paper, rather than just filing it away right away, be sure and talk about it and let the people know what they would like, or what you would like. Next, you should probably get a copy to the hospital or to your doctor's office. If you are seeing a doctor in the Samaritan Health system, then you just need to go to one or the other, because that will be in your electronic medical record and will be available no matter where you are in Samaritan. And so you just need to take it in, like at the hospitals in Albany and Lebanon, where I am. You can just bring it by to the registration desk when you come in near the front door, and they just ask them to scan it in. It's a little trickier during this time of COVID, but I think if you were to explain your situation, they should be able to get you, the screeners should be allowed to get you so that your records could be scanned in. The other option is to take it to your clinic and have it scanned in there. If you are in a different clinic, for example, if you're also seeking care with the Corvallis Clinic, you may need to take a separate copy to them, because our medical records don't communicate with one another. You want to be sure and keep the original in a safe space. That's someplace safe but not locked away, because if you lock it away and then something critical happens and your folks can't get to it, then it's not going to do much good. Ideally, you will have already got it scanned into your medical record, but just in case you're in another hospital system or someplace that needs it, you want to be sure and have it accessible. I've heard from some people that they have it locked in their safety deposit box, and that's not very accessible. So you might consider where you keep it. And then remember that you can always come back to it and update either of these forms in the future. In fact, we have people often with the POLST, when you get to that point where you're filling that form out, there are people that go back and forth and they fill out a number of them over the last few months of their life, switching back and forth. And it's perfectly acceptable to do that. I was telling a family yesterday about how there was a case where a gentleman was a do not resuscitate, so he had a POLST that said don't do anything like that. But then he learned that he was going to be a grandfather, and he decided he wanted to do more aggressive treatment. So he chose full CPR and full treatment until his new grandchild was born. And then once that happened, then he was able to hold the child and be with the child, and he decided, okay, at this point I'm wanting to go back to do not resuscitate, and so he switched back. So that's just another example of how these forms can be used to express what your wishes are, depending on where you are in what dictates your quality of life. Finally, our closing suggestions. If you haven't already, I think I've sort of pounded this into your head today. Spend some time thinking about your current quality of life and where you are on that. And then maybe imagine what some intolerable quality of life might be. A phrase that I've used with some folks is to consider what might be a life worse than death for you. If you were kept alive to live out your life in a certain way, is there a way that you might regret, gosh, I wouldn't want to be kept alive if I was in this condition? And so think about those types of things, because these are the types of things not only that you can think about, but you can write in your advanced directive because they have some lines and additional spacing for that. So you can write some additional notes, and that means being able to define what your quality of life might be. Also, we encourage you to complete the advanced medical document that's appropriate for you. If it's an advanced directive or if it's a POLST, you can do that. You can make appointments to come see me, to see Molly. You can see your doc. There are a number of different ways that you can get these forms filled out, and so we'd love to have you figure that out and be able to fill out the form that's appropriate for you. And then, as I said in the last slide, please be sure to tell your family and friends and folks what your wishes are. So that they know what they are. I think that wraps up our prepared slides. At this point, we can switch to answering some questions. Do we have any questions that we should be addressing?
We've had a few. Hi Anna. Can we get these slides after the webinar? Erin, I believe you're sending them to participants, sending them a link to this. So you will get a follow-up email from Erin, and she'll let you know how to access the recording or the slides.
You'll get an email with the recording and a link to a survey.
And then a question about time limits on how long you would want life support or limits to cost of care. Yes, there are a lot of places to write in commentary, and that's very helpful for your family to know if this is the situation, then I'd like to do this, but if something else, then maybe not. And I've seen a lot of people say, let's try it. Let's try life support for a short period of time and see whether there's any improvement, and if after a set period of time nothing's improved, then let me go, but not ready to not try it. That's certainly something to write in and discuss with your family. There are sections on the form to do that.
It's not going to come in with my effect, so I was going to try and show the lines where you can write that in. But.
And the same, if there are limits to cost of care, make sure your family's aware of that, and yes, write it in. There's no guarantees, of course. If you're not on life support, you can't, so to speak, pull the plug quite so easily. So discussing other things to do with quality of life, whether you would be, how you feel about living in a facility, how you feel about being bedbound, how you feel about communication, because all of those things are could play in and could play into what cost will be. Downloading the form and uploading it, I believe the answer is no, because you have to complete, well, for POLST, that has to be completed with a physician. For the advanced directive, I don't actually know the answer. There may be an answer on the advanced directive website, or do you know, Wes?
As to
whether you can download the form and upload it to your own electronic medical record.
At this point, I'm not aware that we can do that. I was wondering about that through my chart, whether it's possible to upload it, but I think you still have to have it physically taken to the clinic or the hospital. If we ever get to a point where we can do that and upload it, that would be wonderful. As far as downloading, yes, you can, if you don't have the document handy or you don't have access to one, if you go online and just do a search for Oregon's Advanced Directive, you should come up with our actual directive. I have actually had people who've brought it in that they've printed off the internet. So it is downloadable in the sense that you can print it off and have it available to fill out if you don't have the actual booklet in front of you. So yeah, one of the other things that I might add that you can throw in when you're making comments, I often encourage people that if you are passionate about being an organ donor, for example, that is something to write in, because that allows us, your medical team, to know that if you were in a situation where we needed to keep you on a breathing machine, for example, in order to allow you to donate your organs, which is a passion for you or something you're interested in, then we know that it's okay to do that. Whereas for many people, it's like, well, if I'm in this condition, I don't want to be kept alive, but I'm willing to be kept alive if I can do something, donate my organs in this way. And so that's another key thing to write down to let your family and folks know. Also, I'll just put a plug in as a chaplain. I'm always grateful if I see that somebody has, if they come from a particular spiritual tradition, faith tradition, and it's important for them to say, for example, from a Catholic tradition, to have the priest come and say a blessing or to do an anointing. Writing that in as additional instructions can also be very helpful because then it lets us know if you're at a time where you can't communicate, that you've communicated in advance that you really want to have your pastor or your faith leader come to be a part of your care. So that's also another thing to consider jotting down.
Question asking if we're doing telemed appointments. Wes, if you could go to the next slide.
Oh, sure.
Both Wes and I have said that we'd be very happy to follow up with anybody if they have questions or want to walk through this individually. It's within the spectrum of both of our jobs. So there's our contact information, and I would welcome anyone to call me or email, and I would be happy to meet with you either over telemed or on the phone or even in person if we're taking the precautions that is our protocol right now. And I've also put in the POLST website and the Advanced Directive website, which both are very good, have a lot of what if this, what if that, and good videos, good information for helping you think through some of this stuff. So yes, we would be available. And question, if you have an advanced directive and a power of attorney, do you also need a healthcare power of attorney? Healthcare power of attorney is, I think I use that term interchangeably with healthcare representative, which the advanced directive does name. So that would not be needed. And the power of attorney, I think of as for financial and legal affairs and not for healthcare. But if your advanced directive names a healthcare representative, then the answer is no, you don't also need a healthcare power of attorney.
That's my understanding as well, yes.
See if anyone else snuck any questions in there that we didn't see.
Basically, these are very challenging conversations to have, but I do realize that during this time of COVID, that's a little bit more pressing for some people as they've recognized the possibility of needing to be on a ventilator or going through certain medical treatment. And so really very much respect the fact that you've joined us today and are willing to look at this and to be thinking about it. So if you are a medical person and have joined us today, I strongly encourage you to consider having your advanced directive done. I've got mine done. I think it's important for us to do ourselves and not just talk about it, but actually do it as well. And believe it or not, I had mine done before I started working in the hospital system 15 years ago. So it's just one of those things that I've been passionate about for a long time. But I think as medical personnel, it's helpful if we do our own as well.
And Wes and I both, I think, have been having these conversations for such a long time that we sometimes forget how difficult they can be. So yes, it is a difficult topic, and I would. It's very. I mean, I would love it if every family in America did sit down and discuss these topics. It's really helpful in the hospital when something comes up, when families know in advance how people feel about these things. And our program does that all the time, and we also have information about how to talk to your family. So if that can be helpful beyond what's in the Advanced Directive workbook, again, we're here to help with that.
I don't see any more questions, so maybe we should just go ahead and wind down. Thank you very much for joining us. Molly, do you have anything else you'd like to say too?
Thank you. I'd like to say thank you.
Yeah, thank you again for joining us today. Thank you, Wes and Molly, for this wonderful presentation. For the attendees, your feedback is valued. If you could please take a moment to complete the brief survey, which is now available in the Q&A box. And then please watch for the follow-up email that will include a link to the recording as well as the survey. Thank you so much and have a wonderful day.
Thank you.
Take care all.